Welcome to Healthcare AI Weekly. I'm Raphael Malikian. This is the show where we take new peer-reviewed healthcare artificial intelligence papers and translate them into practical, clinically grounded takeaways. Today we have one major paper on large language model diagnostic reasoning in epilepsy and one overlooked but very important paper on nurse concern signals for inpatient deterioration. Quick housekeeping. If this kind of evidence-based AI journal club is useful to you, please like the video and subscribe. It helps the channel reach clinicians, builders, researchers, and healthcare leaders who want more signal and less hype. First, the major paper of the week, Evaluating Large Language Models for Diagnostic Reasoning from Unstructured Clinical Narratives in Epilepsy by Dani and colleagues. The important point is that this is not just another clean multiple-choice benchmark. The authors are working with messy clinical narratives, the kind of real language that appears in actual healthcare. The clinical task is to reason from seizure descriptions toward likely onset zones. That matters because a model that looks impressive on tidy questions may behave very differently when the input looks like real practice. Here is the key performance lesson. The model behavior changed substantially depending on prompt design. In plain English, the instructions you give the model are part of the system, not a tiny detail. Figure 2 is useful because it shows performance, calibration, confidence, and comparative behavior visually. For healthcare AI, this means we should not only ask whether the answer is right. We should ask whether the model knows when it might be wrong, and whether the evaluation setup matches the workflow where it will actually be used. Now the caveat, and this is the part one would highlight for any hospital executive or AI product team. A correct answer is not the same thing as trustworthy reasoning. Expert review can reveal flawed rationale even when the final prediction looks good. In clinical AI, that matters because the explanation may influence a clinician's confidence. If an AI system is right for the wrong reason or cites something inaccurately, you have a governance problem, not just a product problem. Quick pause before we move on. If this format is helpful, please hit like and subscribe. It tells YouTube that careful, source-based healthcare AI analysis deserves to be seen. And I have a question for you. Should reasoning audits be required before any AI model is used in clinical decision support? Drop your answer in the comments. Figure 4 brings this into implementation territory. Role framing, narrative length, and language context all affected outputs. That means a model can be validated in one prompt setup and then behave differently after a workflow team changes the prompt, the note structure, or the language context. This is why prompt governance should be treated like clinical configuration management. You need versioning, monitoring, and local validation, not just a model name and a confident demo. Now to the paper people may have missed, Enhancing Prediction of Inpatient Deterioration by Combining Clinical and Nurse Concern Features, by Juan and colleagues. It is less flashy than an LLM paper, but it may be closer to the kind of AI that changes hospital operations. The idea is that nursing documentation and nurse concern patterns can contain early signals that a patient is deteriorating. That is healthcare AI as workflow intelligence rather than chatbot theater. The methods are a little technical, but the practical question is simple. The authors compared clinical features, nurse concern features, and combinations of those signals. They also tested temporal clustering, including K-shape clustering, which is a way of grouping time patterns that have similar shapes. But the key implementation question is not whether the method sounds sophisticated. It is whether the signal improves prediction in a way that can survive real hospital workflows. The result to remember is the combined signal. F-measure combines precision and recall, so it is useful when you care about catching true deterioration without drowning the system in false alarms. In this paper, clinical-only features had an F-measure around 0.16. Nurse concern features alone were around 0.19. The combined clinical and nurse concern features reached about 0.25. That is still not magic, but it is a meaningful signal that human workflow information adds value. Here is the discussion question for this segment. Is nursing documentation a safety signal we should use, or does it risk turning everyday clinical work into surveillance? I think the answer depends on governance, consent, labor context, and whether the system helps frontline staff rather than punishing them. If you know someone in nursing leadership, hospital operations, or clinical informatics, Share this episode with them and ask what they think. The caveat is local meaning. A documentation pattern in one hospital may not mean the same thing in another hospital. Staffing ratios, unit culture, EHR design, training, and workload can all change what a documentation signal represents. So the takeaway is not, copy this model everywhere. The takeaway is, nursing workflow signals may be valuable, but they need local validation, transparent governance, and feedback loops with the people doing the work. So what connects these two papers? The first paper tells us that large language models may reason impressively, but they need audits, calibration, and prompt governance. The second paper tells us that important clinical signals may already live inside human workflow, especially nursing workflow. Together, they push us toward a more mature version of healthcare AI. Interpretable, local, evidence-based, workflow-aware, and humble about uncertainty. That is it for this episode of Healthcare AI Weekly. If this helped you separate evidence from hype, please like the video. Subscribe for the next episode, where we will keep tracking the healthcare AI papers that matter. And comment with a paper, controversy, or clinical AI question you want me to cover next. I'm Raphael Malikian. Thanks for watching, and I'll see you in the next one.